Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2019. It's day one, and we are here with Dr. Wilens for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
Hi, I just presented on adolescents and adults with ADHD, transitional aged youth, in terms of what the presentation was in the treatment, and I wanted to answer some additional questions. So the first question is, when is it appropriate to consider the use of memantine? And interesting, memantine is a medicine that they use for Alzheimer's disease, and it's also been used recently in autism spectrum. In our own clinical practice and in research that we've published, we found that memantine seems to be helpful for executive function issues that adults or adolescents may have within ADHD. So time management, hierarchical thinking, difficulty with organization. Our experience has been that seems to be improved with individuals who are receiving memantine. And also, like I indicated, sometimes for kids with ADHD or adolescents and adults who have ADHD and autism spectrum, memantine may also be an interesting medicine, both addressing the executive functioning and also having some impact on socialization. The next question is, what is the impact of frequent marijuana use and ADHD and or executive function? And this is a very common question, and one that I'm particularly interested in and have evaluated. First, there's data that it depends when the marijuana use starts. So we worry a lot about kids using marijuana because before the age of 16, 17, 18, in context to a developing brain, the marijuana seems to create new onsets of executive function. So if you check adults, for example, who have been smoking marijuana, the adults who are most affected are those who started their marijuana before the ages of 17, 18, as opposed to those who started a little bit later. So it does seem to be related to that. Now, there's a lot of questions. Does it actually treat ADHD? Kids and adults say, "Oh, I find that it helps my ADHD." In fact, there were studies done overseas that looked at the effects of marijuana on ADHD in young adults and didn't find any major effects, pro or con, on the actual outcome for ADHD. So it didn't work for ADHD. And there are other studies that have been done that shows that it actually may negate the positive effect that stimulants have on treating ADHD. Now, the question of does marijuana use improve or enhance executive functions, it does not appear to do that. In fact, we found that excessive marijuana use in adolescents actually creates new onset of executive function. And there's really mechanistically no plausibility that organization, time management, hierarchical thinking, things like that are going to get better because you smoke marijuana. So the answer probably at the end of the day is it's not particularly helpful. Certainly more studies are necessary, and it's hard to do those studies, but doesn't seem to be efficacious for ADHD. Now, another question is moving into the realm of substance use in ADHD, and it's asking the question, do I have any thoughts on using naltrexone or the extended release intramuscular version called Vivitrol for alcohol use disorders or cravings in adolescents who are younger than 18 when they've already started down early addiction pathway. So I presume it's in context to ADHD. And the answer is we use motivational enhancement therapies. We use cognitive behavioral therapies. There's a number of therapies that are helpful for the individuals themselves or their families. This is an age range all the way through transitional age youth that you want to get the parents involved. But in context to that, if the person can't stop, if they have urges and cravings, then naltrexone is an excellent candidate medicine. In fact, it's FDA approved, and it would be my first out of the gate in those individuals. Other ones that you can use are acamprosate, and then off-label you can use medicines such as gabapentin or topiramate. Next question is, can you discuss your thoughts and approaches for young adults who weren't treated for ADHD as children and present with depression and substance use now as young adults? How do you address that? What do you do? So first of all, you start with a really careful diagnostic. Do you have ADHD? Do you have depression? Do you have a substance use disorder? It is a very common triad. In fact, almost a decade ago, I wrote a paper exactly on that area saying that if you're dealing with ADHD and substance use, you're almost always dealing with another psychiatric disorder, and depression is one of the most common. And what we do is we parcel out which one is the more severe comorbidity and try to address that first. So in this case, if they're really using a lot of substances, we're going to try to get that under control, try to stabilize that depression, and then move in the treatment for the ADHD. The second part to this question is what do you think about using medicines like Vyvanse and atomoxetine? And the answer to that is I think those are both excellent choices. Atomoxetine for people who might want to use a non-stimulant, or if there's a lot of anxiety in the clinical picture along with the depression, and it's also free of abuse liability. Alternatively, medicines that are extended release stimulants like the extended release methylphenidate or amphetamine compounds, in this case it was Vyvanse, but those are all good choices. I would stay away from the immediate release stimulant medications because those are the ones that tend to be misused more frequently. Having said that, I don't want to also give the impression that any of the extended release can't be misused, diverted. They are, but just at a lower frequency than the immediate release. Can you speak to the potential impact and what you've seen in clinical practice regarding Jornay and the sleep disturbance? So Jornay is called a delayed extended release methylphenidate preparation. So you give it at night between 7 to 8 p.m. It releases through the night in the morning, really releases in the morning. And then you'll see it activate around 6, 7 a.m. And it seems to have a long duration of effect through the day into the early evening. We haven't, in clinical practice and in the research studies, the sleep disturbances was no higher than what you see with any methylphenidate product. And I suspect the sleep issues are more related to the dose that was given of the stimulant during the day and not what's occurring at night. So intuitively you would say, oh, you're giving a stimulant at night, it's going to keep people up. But actually it's not being released until 5 or 6 a.m. So I think it's the stimulant that was released the preceding day that leads to that night's sleep disruption, as it is with any stimulant medication. Any reasonable stimulant trial that's been done using best practice clinical trials, you're going to see insomnia as one of the side effects. It's just unfortunately what you see with stimulant medicines. Next question is, how are you selecting amphetamine versus methylphenidate for your patients? It's a really personal choice. So, in general, I sort of think of methylphenidate as a slightly kinder, gentler stimulant medicine for ADHD, one that's a little bit easier to tolerate, but also one that's probably just a little bit less effective than amphetamine. So in general, I default to starting with methylphenidate class agents, and then we'll move on to amphetamines if I'm having difficulty with the methylphenidate response. Having said that, about 50% of my children, adolescents, and adults are on methylphenidate and half are amphetamines. So, and then some people actually ask me, and I've heard this question before, why don't you just do empiric trials of both amphetamine and methylphenidate and see which one works better? And, I don't have a good response to it. I just don't do it, but it seems very logical and reasonable to me. And then there was a question about isomers. When do I pick isomers? In general, I don't use the isomers first, and I would use an isomer, which would be something like D-methylphenidate, which is Focalin, or D-amphetamine, which is Dexedrine, or D-amphetamine, which is Vyvanse. I would use them after typically I've tried the standard formulation, the DL formulation of the medications. Question is, what about off-label use of Nuvigil, armodafinil, which is similar to modafinil, which is Provigil? Actually, modafinil has been studied. What's interesting in the studies with modafinil, every study that was done in children with ADHD was positive. Every study that was done with modafinil in adults was negative. So since I'm focusing on adolescents and adults, I would use it, and I've seen some success in adolescents. I tend not to use it extensively in adults. We think, in terms of its mechanism, it's sort of a weak stimulant. So in general, it's going to perform like a stimulant, and so why not just use a stimulant? But having said that, I've had a few individuals, and other clinicians have noticed the same response, where motivation is one of the major problems with their clinical presentation. And for whatever reason, modafinil seems to be particularly helpful in enhancing motivation. So I've had some successes using it for sort of poorly motivated individuals with ADHD who may have had other symptoms improved with stimulants or non-stimulants, but they still are not motivated. And this compound, modafinil, seems to be helpful, and I would argue armodafinil, which is Nuvigil, would also be helpful for that. But it's off-label, and again, I think you have to use it a little bit of a caveat because all the studies were negative in adults. So when we're using it in adults, it's against a backdrop where there's not a lot of empiric-based data showing that it's highly effective. What is your preferred treatment for ADHD in adults with cardiac histories? The the issue with cardiac histories is that you're going to have to know what the nature of the cardiac history is. So if it's somebody who's had a myocarditis or pericarditis and that they're clear of that and they've been clear for 6 months or a year and there's no evidence of arrhythmias, et cetera, then those situations you can often restart the medications. For people who have myocardial infarctions, again, you're going to have to work with cardiology to try to determine if there's issues with any kind of arrhythmias or reentry problems since the myocardial infarction. For people who have high blood pressure and things like that, those we've actually published on. You can manage them. You have to monitor their blood pressures. No surprise, stimulants can give you high blood pressure, especially if you start with high blood pressure. So for those individuals, I check their blood pressure with most every visit and encourage them to follow up with their primary care physician or cardiologist to monitor that. Having said that, we've had very good success working with our cardiology division to work on using these medicines or reintroducing them to people who have had cardiac events with the understanding that they need the treatment to be able to be functioning. And most cardiologists are very thoughtful about a risk-benefit analysis on that. Question is on Wellbutrin, which is not FDA approved for ADHD. What dose or release do you suggest for adults with ADHD? I typically like the once a day because my experience with the twice a day is that the afternoon is almost always forgotten, or if they take it, it's taken late. And Wellbutrin actually breaks down to amphetamine and it can cause a lot of sleep disruption if taken late. So I like the extended release, the extended release. That's the XL, which is taken once in the morning. The data from many years ago, we did a study with that, indicates that you have to, best dose is 450 milligrams a day, gave the best outcomes. And even at that, you still had about 50 to 60% of individuals respond and about a 30% reduction. So not quite as good as stimulant medications or other non-stimulants. Ideas for managing selling or sharing of stimulant medications. So what do you do to manage that? And the thing that we do is, first of all, educate the young adult about that you shouldn't share, you shouldn't give away. If you do share and something happens, they're invariably going to come back at you, that it could be against the law and you could be held accountable for drug distribution. And if they're in college, it's an ethical breach. Most colleges have policies that talk about substance use and diversion and things, and it's an ethical breach. That's part one. Part two, I try to give a supply that's right-sized for whatever they need. And now with electronic prescribing of controlled substances, you're much easier to beam them right into the pharmacy where they go to school. And we don't give oversupplies. And I think that's also helpful. And then also trying to use things such as extended release as opposed to immediate release stimulants on a regular basis. The next question is, what do you think about patients who say they do better on immediate release stimulants as opposed to extended release? In general, I default to extended release, but there's a number of patients, I would say at least a third of my adolescents and adults, who prefer the immediate release. They think they work better, that they're more effective when they take them. They feel like they have more control over the duration of effect and the onset of action. And simply prefer them. And in individuals where I'm not concerned about abuse liability or misuse or diversion, then I really don't have any problem with that. And I've had excellent outcome with that. And it's only in those individuals who come in with, stories that are beyond belief or are sort of clearly concocted or just don't pass the smell test. Those are the individuals that I may just, say I'm going to cut you back on that, or just give them small supplies of the immediate release to ensure that there isn't misuse or diversion. Can you speak to treatment with stimulants in the older adults? So we don't really talk about it. This is more transitional age youth, but in regard to executive functioning, so we don't discriminate except in our research studies. In our research studies, really a lot of them ended at age 55, and there's no real good reason for that. It was just when we were initially doing the studies, and we did some of the first studies in adult ADHD, we just picked 55 because we didn't want to deal with pre-dementing processes and cerebral vascular issues that were more often onsetting after the age of 55. But there's nothing divine about that age. And so most people can be treated well into their 70s, et cetera, with the stimulants. Now, my personal observation is that many people still have a lot of activities and things that they're doing that they function much better with the stimulants. But what they often will do, it reminds me of kids who are on stimulants for school, but on the vacations they cut their doses back because they don't have the same heavy cognitive load. And I find that in elderly adults that they can cut their dose back. They don't seem to have the same cognitive load because often they're not working, or if they are working, they're working at a reduced hour burden. And so we're able to cut the doses in half or so. And again, I keep an eye on blood pressure, etc. And I've had very good outcomes for people like that. And I think to just withdraw them because people are getting older, I really think it's just discrimination. I don't think there's any data to support that. So I appreciate that type of question. How do you manage patients who are taking stimulants but plan to go to college in Europe? That's a very good question. First of all, Europe is one thing. I'll address Europe first. First of all, we try to give them often a 90-day supply. So the maximum you can give is 90 days according to the federal guidelines. The state, your individual state or commonwealth may have more restrictive guidelines. So you're really obligated to stay with your more restricted guidelines. Generally, I default to 60-day supplies of medication because I think there's too much of a supply when you get to 90 days, even though it's easier for the individual to keep them. And I am a big believer in adherence. I'm also worried about oversupply. So in general, I like 60-day supply, but periodically, when people are going overseas, we'll do an exemption for 90-day supply. Sometimes insurance pays for it, sometimes it doesn't for all of that. I have them carry the medicine right with them. They don't check it, they carry it on the plane with them. Before they travel, they need to, and they have to carry them in the bottles that with all the identification information. Part two. Many of these kids also then travel to other areas. So most of the European Union is fine with stimulant medications, including both methylphenidate and amphetamine. Realize that is not the case with a number of countries around the world. Some countries have stiff fines and prison sentences for individuals who come into the country with amphetamine, even if it's legitimately prescribed Adderall, Adderall XR, Vyvanse, Dexedrine, any of these compounds. If they cross in and they go through border patrol and they're found to have them, they're held as if they had a drug offense, and they could be held for drug distribution because they're often carrying supplies. And I have to tell you that personally I've dealt with writing letters and working with attorneys to try to get kids out of jails. 18 and 19-year-olds are in these jails in these third world countries because they brought their Adderall into the country and there was no misuse or distribution, just for personal use. And they were seen and being held in the same accountability as somebody who is using methamphetamine or other drugs of misuse. So people have to check very carefully the entrance requirements and can they use certain compounds in that country. And the best information you can get from it is going to the embassy's website. And if you don't get a good answer, you really need to call the individual embassy of the country you're going to be going to. I am going to be a little bit more conservative than just that and tell you that after I've dealt with some cases of people who have been in jail because of this, I even worry about if you're transiting through certain cities in case there's a delay or a missed flight and you have to exit and come back in. So I think you have to be very careful that way. There's a question about pharmacologic strategies for poor sleep in the context of stimulants. And what we try to do is first talk about sleep hygiene. What time are you getting up in the morning? What time are you going to sleep at night? You can't tell people when to go to sleep, but you can tell them when to wake up. And then we talk about if all of that is good, watching what you're eating, no caffeine, all of this typical blue light, which, by the way, does keep you awake, things like that. Let's say you've done all of that and they're still having problems. We try melatonin. Oftentimes we can try low doses of clonidine in adolescents. We do in adults, but not quite as much. Sometimes people use prazosin in adults. And then some of the sedating antidepressants, low doses like mirtazapine, 7.5 milligrams, or amitriptyline or imipramine, 25 to 50 milligrams. I try to avoid benzos. I use non-addictive kind of compounds, and I think that we've had really good outcomes when you help improve the sleep. Is there a blood level of cannabis which we could determine would be consistent with misuse versus addiction? And that's in context to ADHD. The most common misuse is marijuana. So the answer is yes and no. They're guidelines. These are not invariant. And that is that typically people who are less than 100 or 200 could be smoking for medical reasons, could be using intermittently. But once you get north of 200, 250, 300, 400, 500, unless you just smoked right before you had the blood level. So let's assume you didn't smoke an hour before. That's an indicator that people are smoking quite a bit on a regular frequency. So really much over 200, and that would raise an alarm. So we have one more question, and that is, when subtherapeutic response is seen on a certain dose of a stimulant, when, if ever, should you consider switching agents rather than maxing out the current stimulant dose? That's a great question. What we typically think of is you're going up on the dose. In your head, you're drawing sort of the efficacy curve, and you go up on the dose, you get a good response, it's linear, and then all of a sudden, you've gone up and maybe a little bit better. Usually when you start hitting that maybe a little bit better, you have to then balance it to side effects. And if you've done that and your sense is that you still have a lot of symptoms, then you're probably relegated to switching to another stimulant. Now, I usually stay, if I've had some efficacy, within class. And sometimes I'll switch to an isomer. So sometimes if I'm using, let's say, Concerta, I might move to Focalin XR. Alternatively, if you've done it and you've tried, let's say, 2 methylphenidate class agents and you keep getting close but no cigar, then I would move to an amphetamine. I would just say it's time to try an amphetamine compound. The other reason I would shift is if they were on methylphenidate and they didn't like it. So, for example, over-focusing, you get adults who just say, I treat attorneys, for example, who say, when I'm on the medicine, it works. I'm focused, but I can't think creatively. And if I'm in court, I'm not able to be as relational and accessing information that's absolutely necessary on the fly. And for those individuals, I find shifting into amphetamine, for example, really helps their focus and attention, but doesn't tend to be as constricting. So I think you have to be thoughtful about the balance of does it work plus the side effects of the medication.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Congress 2019, and make sure to subscribe.